Hello, everyone, and thank you for joining us today. My name is Rodney Fong, President and CEO of the San Francisco Chamber of Commerce, and we are very excited today to have a special guest who we saw 9 months ago, Dr. George Rutherford from UCSF. Dr. Rutherford was here with us. We're all still sort of in shock by this in May 2020, just when we were beginning to talk about shelter in place and the impacts of COVID on our community. As everyone knows, this has been a real journey for all of us, and we're excited to hear Dr. Rutherford, as he's the leader in the pandemic study, been active with the city of San Francisco, has been really, UCSF has been an incredible partner for the city of San Francisco, and we begin to look at where the city's numbers are in comparison to other places, and I think we all should be so proud of that. A little bit about Dr. Rutherford. He is the head of the Division of Infectious Diseases, Global Epidemiology, in the Department of Epidemiology and Biostatistics at UCSF School of Medicine. His work is focused on the prevention of infectious diseases, tropical diseases, and public health importance, both internationally and domestically. His primary focus is on HIV and AIDS. And like many folks at UCSF, they turned their focus to COVID-19 during this pandemic. So again, before we start, I want to thank UCSF and Dr. Rutherford for their really ongoing support with the city of San Francisco. As a longtime resident, all of us, we're not sure exactly where we'd be without UCSF and you. So I'll turn it over and we'll use the chat room as we always do for any questions, comments, after the presentation. So Dr. Rutherford, thank you again. 9 months later, you look great. Thanks very much for joining us.
I was saying how much better you look than I look, So anyway, thank you very much. I'm going to go ahead and share my screen and get started here. Happy St. Patrick's Day, everyone. I couldn't pass that one up. I actually had to go back and find a green shirt in my closet today. So I'm going to try and talk about, what's going on and kind of what could go right and what could go wrong. Currently in the United States, this is as of Monday, Monday late afternoon, there had been 29.5 million cases of COVID-19 reported. It's been falling. I'll get to that on the last slide, but we're still having in excess of 50,000 cases a day on average. We've been past this astronomical figure of 500,000 deaths from COVID. The total's actually higher if you start counting in all sorts of other things. And we're still running sort of roughly on about 1,500 deaths a day. This was kind of an anomalous low day. In California, we've had 3.6 million cases. And we're still running at kind of at a clip of about 35, somewhere between 3,000 and 3,500 cases a day. And we've had, again, an unbelievable toll of 55,942 total deaths and 129 more on Monday. Statewide, this is a number that we look at that's actually published by the state every day. This is the effective reproductive number. And what it means is that for every one case, how many people will that person transmit to on average? So there's so if you think about, if I'm infected and I transmit to, one person, and that's what it is across the entire population, the effective reproductive rate is 1. And that means the disease stays at the same rate, at the same level throughout the population. If it's more than 1, it increases. If it's less than 1, it goes away. We've also had this continued drop in the proportion of all tests done across the state that are positive, from a high of about 14% back in January down to 1.8% yesterday. Hospitalizations have continued to fall. They're currently down 37% from 2 weeks ago. Our ICU capacity has gone way back up, especially in Southern California. And we're currently at a rate of about 8 cases per 100,000 per day statewide, and about 0.57 deaths per 100,000 per day statewide. This is the new map of closures in California. And you can see that all of Southern California, with the exception of Kern and Inyo counties, have gone into the red tier. The purple tier is here predominantly in the San Joaquin Valley, with the exception of Tulare, and these are actually mountains. Mariposa, let me see if I can get this right. Mariposa, Tuolumne, Amador. No, that's right. This is Amador. I know Calaveras is in here somewhere too, but this is Mariposa. I know that, and that's been in the kind of these low tiers for a long time, and of course Alpine with 0 people in it. But San Mateo has come into the orange tier, and there's an expectation that San Francisco will go to the orange tier next week as well. This is the current lineup as of Monday in terms of cases and case rates, right? So this is all in kind of red or orange levels. The effective reproductive numbers are all well below 1, and the percent positives are also way down here as we go up and down the list. This is what the shape looks like in the Bay Area. We've had 340 cases on March 15th, and this is what the mortality rate is. There have been 5,653 deaths in the Bay Area total from COVID since the beginning of the outbreak, and we're still had 14 more on Monday. If you look across the counties, Santa Clara, which has had the most cases and the most deaths, is going down. Alameda is going down, although there's a little blip here. Contra Costa is finally starting to come down. San Mateo is way down, has done a really good job. This is just kind of a stabilization out. San Francisco's done a really incredible job. There are 446 deaths in San Francisco. In 1918, 1919, in the influenza pandemic, with a population of 350,000, and with about the same kinds of interventions available in terms of masks and social distancing stuff, San Francisco had 3,000 deaths. So you can see how much better we're doing. In Solano, Sonoma, Marin, and Napa. Our way out of this is through vaccination. California has been very aggressive with vaccines as long as we can get them from the federal government. We've had 12.6 million doses administered as of this morning. Yesterday, there were 464,000 doses administered, which is quite remarkable. And we're actually running at a clip of around 300,000 doses a day here recently. At that rate, we're going to be immunizing something like 2 million people a week. And if we have, say, 10% of all Californians vaccinated, that's around, of adults, that's around 3 million people. And we're going to be vaccinating almost that many every week. So that's a lot, right? And you can see here, San Francisco's down here, but just because we don't have a lot of people, but we have had 41% of our population has received at least one dose. Now, there's a lot of discussion about the vaccines because a new third vaccine came into, it was authorized a few weeks ago. That's the Johnson & Johnson vaccine. That's their Janssen division. So some people say Janssen, others say Johnson & Johnson. This is the numbers that people are walking around with in their head. And this is the vaccine's efficacy, different efficacy against having COVID with any symptoms at all. Everything from mild symptoms up to death. Right, so this is somewhat less effective. However, as opposed to the Pfizer and the Moderna, these trials were done in countries in which there were a lot of variants circulating at the time of the actual study. So in South Africa, 90% of the cases that this vaccine was used for had the South African variant. So it's not a fair comparison to look across these. Although this probably is somewhat less effective than these others, but it's very marginal. And you can see how wide these confidence intervals are, and they come close to overlapping. Anyway, be that as it may, this is an incredibly effective vaccine, and you can get protected in one dose with the Janssen vaccine as opposed to these other two that require 2 doses. If you look at efficacy against severe disease, there were 0 cases in the Moderna in the vaccine recipients in the trials. There was 1 case in the Pfizer, and there are 5 cases in the Janssen trial, and that's what these numbers equate to. But if you look at death, all were 100% protective against death. Okay, so that's kind of where we are. Now, the question is what can go wrong? You know, this is all pointing in the right direction. Everything's looking good. We're moving down the runway, light at the end of the tunnel. You pick your analogy. The first thing is that we have a critical period from now until about the 4th of July where we got to get as many people vaccinated as possible. And if we have outbreaks of transmission, it's going to make it more difficult, because when you have transmission begets variants. And if the variants can elude the vaccine, that's a problem. Okay. So we don't want outbreaks. So first thing is we have mask fatigue and breakdown of so-called non-pharmaceutical interventions, meaning masks, meaning social distancing, meaning avoiding crowded indoor settings that are poorly ventilated. A second thing is that we don't get the vaccine distributed evenly, and there are large pockets of people who don't get vaccinated at all, and for either because they're hesitant, because it's not available to them, because it's too much of a hassle, because they're not documented, they don't have documentation papers, and they're hesitant to go to government clinics, whatever, right? But we end up with substantial pockets of immunologic inequity, as we say, that can sustain epidemic transmission. And this is probably not so much the Bay Area, but think East and South Los Angeles, where a lot of workers come from, and there's some serious problems with under-vaccination in those areas. We can have emergence of more transmissible or less immunologically susceptible variants. By less immunologically susceptible, I mean that that if you got this strain of virus, that the vaccine may not be as protective as it is with the current strains we're dealing with. And then finally, the other thing I think is a big deal is ignoring international spread. And San Francisco is an international city, but it's not. But we are susceptible to what goes on in Asia, what goes on in Latin America, and what goes on in Europe. And if epidemics aren't controlled there and there's continued breeding of variants, we can have continued reintroduction or introduction of variants. So just a couple of examples. These are San Francisco's data. So here we are back in September and October. On September 1st, we moved from the purple. This was the summer surge. We moved from the purple to the red tier. On September 30th, we moved from the red to the orange tier. And October 20th, we moved from the orange to the yellow tier. That lasted about a week and a half before everything went up again. So we've been down this path before, okay? And this is what happened. I'm not saying this is because of things that San Franciscans did. This is probably all coming in from the outside. But suffice it to say that we've been down this path before, and there was a lot of that led to the winter surge. Maybe not causally, but it was at least associated in time with the start of the winter surge. We've now moved from the purple to the red tier, which is why things are getting to be reopened. We anticipate next week moving from the red to the orange, and 3 weeks after that, moving from the orange to the yellow if everything keeps going in the right direction. Here's an example of what can go wrong. This is the state of Texas. And you can see that they had their drop off. There was a big rebound. And at the top of the rebound, the governor of Texas said, throw away your masks. We are not doing any more restrictions at all. This has luckily continued to go down, but I think they're starting to buy themselves some slowing of their decrease at least. And I'll come back to that at the end. Now, what about this problem with pockets of underimmunization? Well, California's paid very close attention to something called what originally was phrased as a health equity index, and then later now in a new metric, the vaccine equity. And what these are, they refer to moving from purple to red to orange to yellow. These are criteria that the state employs in assigning tiers. The health equity metric says if you take all the census tracts in a county and you can array them by a metric called the Healthy Places Index, which has to do with income, education, health insurance, availability of this or that. And it's a way to array census tracts essentially by opportunity, by poverty, however you want to think of it. And what the health equity metric says is that the proportion of test positive among residents of the highest quartile of those census tracts and the lowest quartile of those census tracts have to be close. We can't have, sort of one group doing really, really well and the other group doing bad. And so this says you have to be within a certain number of percentage points to progress from purple to red, from red to orange, from orange to yellow. Now, the governor has imposed on that an additional metric, an additional initiative called the vaccine equity metric. And what the concern is that also, if we look at here at these Healthy Places Index scores, the people in the lowest quartile are not getting vaccinated at the same rate as people in the highest quartile. And the concern is that this is a function of under availability of vaccines. Now, there may be more vaccine hesitancy, there may be other things going on, but what the state wants to do is get rid of non-availability as a reason for this under-immunization. So the state has set aside up to 40% of doses, up to 4 million doses, to bring this group up to parity with the rest of the quartiles. And once this gets done, once we get 4 million doses out, we can start relaxing the case rates in the quartile. So right now, if you have, what keeps you in purple is having more than 7 cases per 100,000 per day, and so on down the line. If you get 2 million doses, you get to go to 10, right? That's pretty good, right? More than 10, so you get relaxed. So you can move from purple to red if you're at, 8, 9, or 8 or 9. Okay, 8, 9, or 10. Once you get to 4 million doses, right, this doesn't change. The bottom of this is still 4. When you get to 4 million doses, this goes up to 6, and the yellow goes from less than 1 to less than 2. So you can see if the idea is to push vaccines, try and eliminate this gradient, and the reward is that we can, as those areas get more immunized, and by the way, that's where almost half of transmission has gone on. So this is about stopping transmission. To me, this is about as much about stopping transmission as it is an equity issue. This is a practical public health intervention to try and stop as much transmission as possible, vaccinating people in the areas in which transmission has been going on. So as we get, so the reward for the for counties that make this happen is that they can move up this, they can have a more relaxed tier structure. And the reason they can get away with this is because there's much less transmission. Now, the third thing that I spoke about is variants. Now, what variants are strains of the virus that have accumulated a series of mutations that make them either, it's just, that's it. So viruses mutate. They mutate about every 3 times they reproduce. Most of the mutations, 99%, don't bestow any advantage to the virus, and they're in fact probably lethal mutations. About 1% or so give some modest advantage to the virus, or make it or neutral. Okay, So what happens with these variants? These are variants on a single protein in the on the virus. So here's the virus, big ball. There's this thing that sticks up off of it, the spike protein, and there are a bunch of them. That's why this looks like a crown. That's why it's called coronavirus. So you got the spike sticking up, okay? The spike sticking up, that is a single protein, and it has something like 1,400 and some odd amino acids in it. And what these variants are single amino acid changes. But you can change from an amino acid that keeps the configuration, if you can see my hands, it keeps the configuration straight, to one that may bend it or somehow, have create a situation in which part of the protein gets refolded in a different way. The reason that's important is for the vaccines to work and for naturally acquired immunity to work, antibodies have to come down out of the blood system and bind to the virus, right? And if all of a sudden you've changed or hidden the sites where the antibodies are supposed to bind, they don't work as well. So that's what we're worried about. And there are three main variants that we talk about. There's a so-called UK variant, which came from Britain. And this is really sweeping across the country. It's in all 50 states now. And it's it's more easily transmissible. And there are some data from Britain that suggest it's associated with more severe disease. But it seems equally susceptible to the vaccine. That's the good news. There's another variant from South Africa. This has some decreased susceptibility to vaccination and to naturally acquired immunity, which is of concern. And another variant from Brazil. There's actually one case of this in San Bernardino County right now. As we recognize these things, we do intensive contact tracing, isolation, quarantine, all those sorts of activities to prevent transmission. So we're on the lookout for these, and that's the problem with them. Interestingly, on the West Coast, there's some homegrown variants that seem to be somewhat more transmissible, but they're really much more common than the UK variant. And at least I think they may be out competing the UK variant and pushing it out, so that our dominant strains here on the West Coast may turn out to be these relatively more benign West Coast variants, the 427, the 429. Nobody really keeps great data on these. This was from a couple of weeks ago. This is actually from yesterday. So you can see how there are lots more of these than there are of the B117 variant in California, the UK variant. Okay, and this just gives you an idea. These are data from Joe DeRisi from the Chan Zuckerberg Biohub down in Mission Bay. They went to 24th and Mission to the transit hub there and enrolled people in a study. And of the isolates they found, 15.7% were these West Coast variants. Okay, they went back in January, and this had increased to 55% were West Coast variants, and none of these others are the UK variant or the South African variant or the Brazilian variant. These are just other kinds of mutations that we really don't care that much about. But this is what's pushing everybody out, and it seems to be out competing these other viruses, which is fine because it's maybe slightly more transmissible in humans. It seems to be vaccine susceptible. Okay, now the real question is can the available vaccines protect against these variants? And what we're trying to do here, this ACE2 is the thing on the cell. This is the keyhole on the cell to which the spike protein anchors, right? And so there are certain, these are amino acid changes at these different things. And this makes it, this one and this one make it so that it sticks more easily to the ACE receptor. So that's what translates as increased transmissibility. This one basically changes the folding a little bit, so it still works for the ACE receptor, but it blocks off the antibodies to a certain extent. So It's not 100%, but the antibodies are about sixfold less well. Now, overall, compared to natural infection, the antibodies from vaccines work 17 times better. So a sixfold drop is not the end of the world. They're still working 3 times better. But that may be whistling past the graveyard. So the answer is yes, current vaccines are effective enough against major variants, especially for protection against symptomatic disease. Now, what about imported disease? Europe is in a third wave of its epidemic. It's just starting back up again, and it's never really gone away. This is the early one that we saw, those horrible pictures from Italy, and they had a long summer, and then it started back up here in the early fall, and they've had a big fall surge, much like we did, and now they're kind of re-entering another phase here. A lot of this is in Eastern and Central Europe, but it's pretty well spread out, and this is a concern because these people, these are people from countries that are our trading partners. These are people from whom tourists come. And, just give you an example. Let me see if we can find Italy here. So Italy is this kind of silver gray color. And you can see how this is, big outbreak, kind of goes down. And now it's starting to come back up again. Having had to translate Italian on Muni, much to my surprise, a few times. I believe me, there are Italian tourists in San Francisco. And this just gives you a map of showing you where it is here in the Czech Republic. Hungary, especially hard hit. We don't get a lot of Estonians here, but you can see in northern Italy, this is really, there's a lot of stuff going on. And a lot of this is the Lombardy region, which is where it was so heavily hit before. Okay. Now, part of the things we're doing is that there's something called COVAX, which is a United Nations effort for wealthier countries to donate money or donate vaccines to provide them to less developed countries. And I was pleased to see that President Biden pledged $4 billion for the global COVAX campaign here back in February. Here we are in Khartoum in Sudan and in Phnom Penh in Cambodia, with shipments coming in for distribution, which is great. Okay, now, so that's all good. We're all pointed in the right direction. Now the bad news. Oh, sorry, not yet. These are basically projections for the United States. This is a kind of worst scenario where we get kind of a smallish spring bump and then it drops off. This is a kind of the standard current projection, and this is you get a quicker drop off. And this is with the universal masks, which is what President Biden is trying to get everybody to do. We get even more rapid drop off. So, kind of the worst case we're seeing, this will be a little bit lower here in July if things get worse. But if, based on current projections, we're going to be in pretty good shape by the end of July. Here we are in California, very similar with a prognosis for worst case, is bumping up here in April, May, and the normal and with the universal masking, which you pretty much have already with major drop-offs going forward. Now the bad news. Oop. This is in the Washington Post today. So after weeks of declining cases, echoes of hot spots emerge in upper Midwest and New York City area. This is probably due to variants, and it's probably due to the UK variant. So there are cases in New Jersey falling, and now have started to go back up. Here in Michigan, the cases have started to go back up as well. We'll see where those go, but this is a pretty important cautionary note that it's not time to do a victory lap quite yet. And we need to be really on guard that these new variants don't start causing disease. By the way, a lot of the European outbreaks are due to that UK variant. So that's where we are. I'm happy to stop and answer questions. Thank you.
Thank you. Always entertaining and educational hearing you. I'm impressed by your knowledge of geography in the state of California by county, at least around the Mariposa area. It's just fascinating and to follow the progression of this, and still the story is not done yet.
Yeah.
And where we're going to go, and I take your word of caution of not the time for a victory lap. Hopefully everyone gets that and then continues to be diligent about mask wearing and just using some common sense. A couple of questions that we have here is, in San Francisco, we're starting to see, as you mentioned, a great vaccination rate. Can you give us a little bit of guidance on what you can do socially if you have been vaccinated?
Sure.
Within a group family,
Sure.
maybe one person in your family that isn't vaccinated, what the safest
Sure.
precautions might be?
Sure. So CDC put out guidance about this last week. It's not as complete as we had hoped. What it says is that people, if this is all about couples.
Yeah.
So if one couple has been vaccinated, they can have another vaccinated couple over to their, in a private setting is how it's phrased, and not wear masks. Okay. And if you have a couple who's been vaccinated and another couple, one of whom has not been vaccinated, but is at low risk, meaning they're not a frontline worker or whatever, they don't have to wear masks either. That is a little bit geared towards young children as being the ones who are unvaccinated. You can't there are no vaccines available below 16 yet, 16 years of age yet. And the idea is that it's, can grandparents go see their grandchildren and not wear masks? And the answer to that is, yeah. I mean, it kind of depends on who their grandchildren are. And if they're 21-year-olds living in a fraternity at Cal, that's probably not a hell of a good idea. But if they're, 3-year-olds, then it's probably not, it's probably fine. It all depends on what the unvaccinated person's risk factors look like.
Mm-hmm. Mm-hmm. Next question I have is about herd immunity, and just curious, how do we track that? How is that tracked? When do we think that's even really possible?
Yeah,
with visitorship in and out of the U.S.
Yeah, tough. So herd immunity is a concept from veterinary medicine, as you might imagine, and it's about herds of cattle, and it's about what proportion of the cattle need to be immune, either naturally or vaccine derived, in order for transmission of agents to stop. Right? Basically, they can't find a susceptible host. So it's about an entire population, and you have to think about what the population really is. And if you're having real mixing, like at a regional level, like we do here, then you need to achieve it across the region. And it's a bit of a theoretical construct that is best measured after everything is over and done with. But I can tell you, we've looked at all the data from the state prisons where they've had horrendous outbreaks. And we think that in those situations, which really are like cruise ships or, closed societies, that herd immunity is around 80%, maybe a little higher. And so maybe a little lower too, but it's kind of an approximation. So I think that what we're trying to get to is 70+%. Some people say 80%, but I think it's going to be a squeeze to get to 70%. Because remember, we're not vaccinating adolescents or young children yet, and they're a good chunk of the population. They're 20% of the population. So I think we may be able to vaccinate adolescents by this summer, and we may be able to vaccinate children, say, by next winter. But until then, we're not really going to hit those really high numbers. But children don't transmit very efficiently. Adolescents transmit really efficiently. But you can get them down to 16 years of age now. The Pfizer vaccine's licensed down to 16, as I said. So, I think we may get there. But we're on track to get to 70, 80% of adults vaccinated here in California.
Okay, that is fascinating about our prison system and how that has shifted. We're largely a business audience here at the Chamber of Commerce, and a couple of business-related questions.
Sure.
First one is, San Francisco and so many other large cities are so dependent on the convention business, the meeting
Yeah.
business, the group
Brutal.
gathering.
Yeah.
Yeah, brutal. What do we think, at least for California, rules might be? I'm not asking for a date, but what the rules might be. Would it be like restaurants where we're maybe asking for 25%
Yeah.
capacity, moving to 50, et cetera?
I think you're going to start seeing in April, there'll be guidance out about indoor events. And it's, this is the NBA and the NHL are gonna drive this this issue, and the same sort of things will apply to conventions. I assume that there'll be a density a metric, which would be like 25% of fire marshal approved occupancy. I'm just making up the 25%, but it'll be some number, maybe 20, maybe 10, but whatever it is. And then as you move from orange to yellow, it will go up. Now, what has happened with outdoor events, think baseball games, if it's restricted to people who've been vaccinated or screened for infection that day, you get to double the occupancy. So this leads us to the whole issue of vaccine passports and immunity profiles and things like that, which I can tell you the city has not really embraced, mostly because there's such inequity in vaccine distribution right now. By the time we get to the summer, and basically everybody's had a chance to get vaccinated, then that may change. Yeah, so I think what you do is you let the NBA and the NHL lead the way, and you'll start seeing stuff in April, and maybe even coming into force by mid-April, and then you can start moving from there, and you'll start getting an idea of what you'll be able to do.
Mm-hmm, mm-hmm. And assuming that the equity and inequities of the vaccine accessibility is available all the way around, to the vaccine passport, I'm curious, what agency do you think might undertake that? And would that be,
No, don't believe me, nobody has the slightest idea. I don't know. I don't know if people have been vaccinated in the audience. I stapled mine inside my passport. That's what it looks like. It's a piece of paper.
Yep.
With your name filled in by you. So this is not foolproof by any stretch of the imagination. Mm-hmm. I imagine it would fall to CDC to do that nationally. And it may fall to a health agency to do it in the state.
Yeah.
Please God, not DMV. Although DMV is really efficient these days, I'd have to say.
You could be an organ donor and a vaccinated.
Yeah, you got both. Yeah, and maybe they only want vaccinated organ donors too. You never know.
Yeah. One other business question: what should large and small businesses do to ensure their staff and customers are staying safe? And I think we're seeing it on the ground. When you walk into a takeout location, but is there anything further that we can do as we, hopefully become a little more comfortable, but not too comfortable?
Yeah,
and that
don't get too comfortable. Don't get too comfortable. For those of you in the food biz, including restaurants, your workers can all get vaccinated now. They're in tier 1B. So I would, and I assume they're probably, for people who do private security, people are all vaccinatable now as well. But for non-food, non-security retail, I think, you basically, we're in this transitional period between no vaccine and lots of vaccine. And by the time we get to July, you as a private business can insist that your workers have been immunized. Now, I'm not going to recommend that, but that would be your prerogative. If you're in a public thing, we probably can't do that until the vaccines have been licensed. Right now, they're under emergency authorization. We would expect them to be licensed late May, early June, something like that. Once they get licensed, then you can start seeing requirements for schools, requirements for travel, requirements for this. for certain types of employment. Right now, it's not even, the US doesn't require it for the military, just to give you the kind of the farthest out scenario.
Okay, thank you. And I'm sure you have said this a thousand times, but worth it again. What is one of the questions we have? What is the best source for checking when we are all eligible for the vaccine?
It's whatever that thing's called. My turn.
My turn.
My turn. Yeah. It's probably the best.
Okay. Okay. Very good. Maybe just one more question, and this is a question I have. What have we learned from all of this? And you know, it seems like a long time, a year in shelter in place, but you think about how a vaccine was created in a very short period of time.
Yeah.
And I'm curious, you know, going forward, how will this science accelerate exponentially when it comes to maybe other disease prevention or cure, or even what we know for decades is the common flu shot? How much better potentially can these get over not just next year, but the years going forward?
Yeah. So we refer to this as the Tang question. Like, what did we get out of the space program? We got Tang out of the space program.
Yeah.
So I think that, you know, this raises a whole new world of therapeutics. And I'm talking about the mRNA, the messenger RNA vaccines, the Moderna and the Pfizer. The others are used previously known technology, the adenovirus vectored vaccines like AstraZeneca, like Johnson & Johnson, like the Russian vaccine Sputnik. I'll use the same technology that we used for Ebola vaccine, which was, you know, space age technology 2 years ago. Now it's been, now we have mRNA vaccine as the space age technology. I think that, you know, don't think about this in terms of vaccines. Think about this in terms of therapeutics for things like cancer. I mean, I think that's what's going to really, I think this technology, I mean, sure, we'll use it for vaccines, but it'll also get heavily used for therapeutics, especially for things like where we're trying to get, you know, things into cells, right? And have those cells make products that resist cancer or that treat cancer or can make insulin if you have diabetes or, you know, whatever. I mean, it's just kind of this endless list of stuff that could potentially happen. So I think you're going to see a lot of therapeutic exploitation of that technology.
Okay, that is that's exciting.
But remember, prevention is worth a pound of cure. So while we hammer on this for COVID with masks and social distancing and avoiding crowded indoor spaces, there's all sorts of other stuff that you can prevent too, like from as simple as wearing a seatbelt to, you know, not getting sunburned, to eating the right stuff, to having your blood pressure checked, to blah 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 blah, right? So there's a long list of this stuff, and make sure you talk to your doctors about it.
Yeah, that's a good reminder, and you know, hopefully we get past this, but this is probably not going to be the last time. To some degree, for the U.S., this is our first rodeo at this, and you look at many Asian countries that have been through this a few times or a couple times. So hopefully the lessons are
you know, our lesson was from 1918. It's just, it was interesting. I just go on for a second. I was in early in March. I was in a call. May have been in person now, with Grant Colfax, the director of health. He's a really totally smart guy, good guy. And both I and my counterpart at Berkeley, Art Reingold, brought up what St. Louis did in the 1918 influenza epidemic as ways to behave. And so the lessons aren't lost. They're just a little bit, you know, when they talk about closing Sunday schools, you know, that probably was a bit lost on the present day and pool halls. That's probably lost a bit. You'd have to do some translating, but that's that was certainly brought up. And, you know, the other thing about San Francisco is that we lived through HIV in the 1980s. And so that produced a lot of lessons, may not have been directly applicable, but in terms of organization, in terms of community relations, in terms of messaging, it's hugely applicable.
Yeah, this is, you know, I think it is a fascinating time we live in. And while this has been a tragedy for so many, and but we're on the cusp of seeing a lot of changes and things for the future that I think hopefully make us all stronger and better and
Yeah.
more well informed. So it is an exciting time for us, I think. Anything else that you want to just mention or close with?
Yeah, we're not out of the woods, as I hope I made clear, and we're starting to see some problems arise. And it's not a time for complacency. It's a time to double down on prevention technology, simple prevention technology of masks and social distancing and avoiding crowded indoor places and getting vaccinated when your turn comes. Once you're vaccinated, you have a little bit of rope, you have some cushion, but we would like to avoid, potential super spreader events, especially with these variants. So please be careful. Please don't push the envelope too much. And we'll see you all on the 4th of July.
Okay, right on. Thank you so much. And you heard it here. Don't let your guard down just yet. Be smart, be diligent, and very much appreciate you, Dr. Rutherford, and UCSF for continuing to be a great partner with the San Francisco Chamber of Commerce. As many of you know, the Chamber of Commerce is celebrating 170 years this year, on this year for the Chamber. And we want to keep everyone informed on this topic and other topics that are going on. So many. We have a weekly newsletter that comes out every Wednesday evening. So if you get a chance to sign up for that, you can find out more about other events and newsletters and updates on sfchamber.com. You can also follow us, of course, on Facebook, Instagram, LinkedIn, Twitter. We don't have a TikTok account yet, but maybe we will soon. And a couple of fun things that are coming up for everybody. San Francisco Chamber of Commerce Member Mixer, March 30th, as well as a state check-in with Treasurer Fiona Ma, executive coffee break on April 29th. Small Business Week, this is something that's it's a national program. This year after COVID, we really need Small Business Year, but we are starting off on May 3rd through 7th with San Francisco Small Business Week. We'd love your participation there. And our big, what used to be 700 people in one room, hopefully we get 700 people online, City Beat Breakfast on June 24th. And again, thank you very much, everybody, for joining. And Dr. Rutherford, thanks for checking in. Really appreciate it.
Pleasure.
Hope to see you soon, and also hope to not see you soon with some good news as the COVID situation gets better.
You bet.
Until then, take care. Thanks a lot.
Bye.